Now I would like to introduce our first speaker and lead conference chair, Dr. Milton Kotelchuck, co-founder and vice president at Day Before Birth, professor of pediatrics at Harvard Medical School, and senior scientist in maternal child health at the Center for Child and Adolescent Health Policy at Massachusetts General Hospital. Dr. Kotelchuck will provide an introduction to the conference and then begin our first session on patient-centered initiatives. Welcome, Dr. Kotelchuck.
Well, first of all, I'm so excited to be here, and as Scott said and others, we've been dreaming about this for a really long time, and I'm just incredibly pleased everybody's here. I thank you all for your coming and for being here, for participating. We started already at breakfast time. That was a brilliant idea for people planning meetings in the future. Have a long breakfast. It's sort of many of us know each other in small groups, and the point of this whole conference is for us to share ideas, get new ideas, exchange, move the field forward. And we started this morning, and I'm really excited about this. I'm going to do two things this morning. I'm probably violating what we told all the other speakers to. I'll probably speak a little too long because I want to both give an introduction to the conference and then also talk about the topic. If I can move ahead. I always start every talk with this schema of a health policy model that I worked with Julie Richmond on, who was a Surgeon General a long time ago. And it says that if we're going to make any improvements in maternal and child health outcomes, we need a knowledge base. In a sense, we know this here. ACT work, the antenatal corticosteroids work. We need social strategies. We need ways of implementing their knowledge into practice. That's what many of you here do. We're working on various ways of making this available. And we also need political will, the ability to command resources, both professional resources and financial resources, to make things happen. And things don't happen unless you have all three of those sectors. And I use this framework to organize both my talk and really the whole conference is organized around this framework. So I want to, just for the introduction, I'm going to introduce this model, talk a little bit about the NIH Translational Research Roadmap. I want to provide a quick context of where we're actually at in the world, and then present my own brief kind of review of where the current state of ACT research and practice is, and then turn to the session. So let me just say about the context of antenatal corticosteroid treatment. So one thing I realized as I did this is that we have as a group have to figure out what the initials are that we're going to use. Everybody seems to use a different set of initials. It's probably really hindering our field's progress. We just have to, maybe we'll vote at the end. I don't really know what we'll use, but everybody uses slightly different terms. I went with ACT. So I just want to point out to you that after many years of things not going well in reproductive health outcomes in this country. They were flat or rising until a few years ago in this country. And many of the initiatives that took place in the late 80s and 90s, which really dominated the way we were thinking, had really not worked well enough. And I thought our federal government and many of us really stopped working. None of us in this room stopped working, but the attention to reproductive health issues really took off again in those last few years. All of a sudden, there's excitement, there's new activities that really have changed, and as we heard, really for good news. And we've had a successful national reproductive health campaign. The March on Dimes campaign to reduce 39 weeks has had a profound effect. We have not had a national reproductive health campaign in a really long time, and one that's successful. And many of you know, tell you in advance, we think ACT should be one of the next really main challenges for us to move. And so we come off of an ability to conduct national campaigns, bringing together professionals and the public health agencies and professional communities, all of us. There's new life course perspectives that emphasize the importance of early life events, of which ACT is one of the most important time at birth that really profoundly affects what's happening, and it brings new attention to this period that gives more oomph to our activity. There's been a tremendous growth in continuous quality initiatives. This is really we've been doing randomized control trials forever, but in fact, it's when we moved from science to engineering, because that's really what I think that distinction is. When we moved to engineering, we started really making progress, and we've made tremendous progress. This is a really big change in the way we've done work, and it's already impacting the way we're thinking about it. NIH gave us the Translational Research Roadmap. I'm really very happy that they came up with this. It took them years to move beyond just finding clinical issues, but really into thinking about translation. I have a few more words to say about that. But most of us are in the translational business. That's what we've been in reproductive health for many, many years. And there's national health care reform. You know, whatever you may think of Obamacare or other things, it is in fact driving a lot of the healthcare decisions in this country, and it offers us opportunities for moving ahead in this area. So it's time for us to move. So I'm going to go through 5 slides real fast just to put everybody on the same page. 3.2% of births in the United States were born between 24 and up to 34 weeks gestation. It's been relatively steady, too high, and has disparate distributions. The consequences of prematurity are well known to everybody in this crowd, both short-term and long-term. I just listed a few. All of us know this. I don't need to persuade you this. While primary prevention of prematurity is actually ideal, that's really what we want to go after. The fact is that we have very few interventions in this country that allow us to decrease the amount of preterm births. And whether we can decrease it, which is still an important goal for us, those babies that are born preterm, ACT, antenatal corticosteroids, is one of the few effective secondary prevention treatments for women and neonates undergoing premature labor. It's the almost only one that we have, and we are not using it as much as we should, as you all know. This is a slide, as I'll tell you, everybody in this room will have comments on every single part of it, and that's the point of this conference, but just put everybody on the same page. It's offered between 24 and 34 weeks gestation. There's special recommendations depending how the presentation is made. It's delivered through betamethasone, either 12 mgs intramuscularly delivered twice every 24 hours, or dexamethasone, 6 milligrams every 12 hours, and 4 doses. We can debate which is better, and many people do. Needs up to 48 hours for maximum effectiveness. It works by reducing the risk of respiratory distress syndrome. That's how we really started this. But ultimately, I think we've from early on found that it also had tremendous impact in reducing serious IVH bleeds and NIC. Okay. So why are we using this? Well, everybody knows ACT, antenatal corticosteroids, are effective. I stole this slide from Jeff Gould. He'll tell you the details about it. We all know this. We've been documenting this for 30 years. There are many people in this room who have been working on this forever. It has a tremendous positive impact. We know it's effective. We don't really, it never hurts to show it again, but we don't need to prove it. We need to get it implemented. Okay, there is no national data on ACT estimates in the country. I mean, everybody keeps calling us and saying, you know, what's the number? You know, how many of this, how many of this? There are no national estimates. There's a very uneven range of ACT estimates that exist. If you look in the birth certificate data from the National Center for Health Statistics, it's 21% in 2012. And it's over 80% in the Vaughan data, and over 85 and even higher in the California Perinatal Quality Care Collaborative. And currently, we only measure the initial ACT administration, not full treatment, and whether sufficient time has elapsed for its effectiveness. I'll come back to that point in a later discussion. The vast majority of eligible mothers arriving at major tertiary hospitals do receive partial course treatment. I work at MGH. Ever hint to any of my colleagues that they don't actually give ACT to everybody? They say, well, yeah, there are 3 reasons we don't. All the major hospitals do it. It's an insult to them to assume that they're not at the highest standards. But nonetheless, we still estimate that over 50% of eligible mothers do not receive a full course of treatment. So let me go through 3 slides using my formula: knowledge-based, social strategy, and political will. The knowledge base for clinical effectiveness is strong. We've known this for 25 years. We don't really need to prove this again. The basic ACT biological research, however, is slightly underdeveloped. The full biological mechanism, the way different pharmaceuticals work, whether they're host factors on the side of the patients, these are areas where we actually have much more research to go. It's not completely obvious all the steps from our intervention to why it's working biologically. Clinical therapeutic experiences are actually well studied. It's probably the one area that we've actually done a fair amount of studies. There's a lot of studies out there about which type of ACT treatment works best in a clinical setting. There's limited research, however, assessing ACT implementation or implementation barriers. That is to say, we don't really study how well we're doing. That's what we're here for this conference, to improve this, but we actually have a relatively limited health service research database about treatment delays. We can show we don't do it, but we don't actually study why we don't do it so well, even though the CQI things are working hard at this. I've already said we have inadequate measurement of ACT utilization, and we really, as I believe, are focusing more on maximizing access to ACT than we are about really measuring its efficacy in the case. And we don't have a national research strategy, and that's what we're hoping to do here today. What about social strategies? That's how you implement things. So we already know about ACTs, our knowledge base, but what about implementation? Innovation of ACT social strategies are limited. You know, we're obviously far from universal. Things have worked in the past. We've focused historically heavily on individual clinician education and responsibility. Do the clinicians do what they're supposed to do? In fact, in this last few years, there's been tremendous progress in hospital and professional standards. That's been the way we've approached our implementation activities. These new efforts and continuous quality improvement, and now also perinatal quality collaboratives, they offer some really innovative ways of making progress that we hadn't made in the earlier year. And we're going to hear a lot about these activities and others from our various speakers. I'm looking forward to hearing our various social strategy. And political will. You know, it's growing. The first group you actually have to persuade to do work in this area is us. The leaders of our field have to be persuaded. Now, most of you aren't going to be hard to persuade. You're here, but nonetheless, we're getting our professional organizations to take over and accept this as a major challenge in political will. And there is growing interest in this both among professionals, national organizations, federal government, the sponsors. The fact is that we could get a lot of sponsors for this conference. It was a stunning and a great achievement to our colleagues that we were actually able to pull off and get support for a conference like this. It wasn't like everybody was like sitting out there, give us a proposal. We struggled to get this conference going. But once it got going, people came on board, and you're all here. So there's new opportunities, the Affordable Care Act and health reform, more receptive national leadership. I hope Michael Liu's coming tomorrow. He said he was, so we'll hear from the head of the Maternal and Child Health Bureau to talk a little bit about this theme. There's been a lot of attention, as I said, to increasing number of activities around reproductive health, health safety, other topics, prematurity more broadly, that this links into, and newer life course rationalization. So this is sort of my overview summary. So in the midst of all this, NIH puts out its translational roadmap, which I'm sure most of you are familiar. It talks about basic research, translation to clinical therapy in patients, translation from bed to bedside and clinical practice, and to public policy. And all four of these topics we are going to discuss at this conference, although probably primarily T3 and T4, how to better foster clinician and hospital implementation, and how to assure national compliance. It's a nice wavelength. I'm delighted that NIH finally is into the translational business, because I think, not to make a pun, but we were kind of premature translational researchers in our field for a long time. That's what our field does, and we do it well. I happen not to love the NIH. You can probably hear from my tone of my voice. I'm not the biggest fan. I'm glad they finally came on board, which they should, and I'm glad ARHQ and others really support it, because it is a good framework for us. It allows our work to be seen as important, because it's the translation that's been our problem, not the knowledge, not the T1, but the T3 and T4. But I do think they follow a kind of a linear model, just for your own thinking. This is sort of a kind of you have a medicine and you want it implemented widely, and so in a way ACT fits perfectly their model. But I do actually like my own model with Julie Richmond a little better, because it reminds us that each sector influences each other sector, and that really to have a national campaign is not to be linear, because linear hasn't been our problem. Getting our different sectors, getting political will. If you get a lot of political will, you get more money for research. If you get more money for research, you'll have more implementation. If you have more implementation, it might tell you what research you need to do. So I like all of those different ways of thinking about it. So this Time for Action conference is a chance for us all to focus on all of the different domains and the various models to broaden our vision of what's needed to advance ACT utilization as a national agenda. That's our real goal here today, and I hope over the course, and we chose our sessions to highlight different themes. We could put them in different order, but we chose different themes, and all of them together are what we're going to need. And we just have to also remember, because most of us in this room are broader than we both work on ACT and more broad objectives, but ACT is one critical part of our larger set of efforts to improve the life course health and development of our newest premature children and simultaneously strengthen their families and our communities. So, and I always like this picture. I never can figure out why I like this picture, but it sort of shows all the different sectors that we're going to need to make progress in reducing prematurity. And again, I just end on my thing. And if you, when you have time and you look at the slide, you'll see how the conference is organized by that model. Okay. Thank you. I'm very delighted to be here today speaking on patient-centered initiatives. Okay, so I'm now going to focus down on one theme. And this is a theme that both relates to as I'm going to argue, knowledge-based social strategy and political will. All three are involved in this topic, and it's one component of what we need for a national initiative. Okay, and Russ is going to make any comments if I slow down enough for him to get a word in edgewise and on what I have to say. Okay, I want to talk about 5 things in this thing, 5 different pathways that led me to think about patient-centered initiatives, a topic which may not be obvious to people what that actually means, but as I go through these things, I think it'll become clearer and clearer what this concept is. So I'm going to talk about these 5 different ways. That's how you'll be able to follow the organization, how I got involved with Russ Ruthen in the day before birth. I'm going to speak about emergency cardiac care treatment. Okay, am I in the right conference here? I'm going to talk about some pilot research on patient-centered pilot research. I'm going to present some new ideas from the MCH Life Course conceptual model, and then I want to talk just very briefly about the women's movement and PCORI initiatives. And then I want to suggest some potential patient-centered initiatives and propose some research and policy recommendations, which I hope more people will do that as the conference goes on. Okay, so how did I get to this conference? So several of you know me quite well in this room. I've obviously been interested in reproductive health for a really long time. And about, 8 years ago, it's now getting a long time, Russ, I get an email one day from a person. I don't know this guy. I get a lot of random emails. I suspect many of you in this room did too. And he was actually referred to me by Aviva Lee Peretz, who delivered Cotelchuck's children, actually, all of them. And he wrote me this thing, and it had a little proposal in it saying how to get hospitals to do antenatal corticosteroids. He already knew the topic. He was writing me, and he had this proposal. How would hospitals should do this? The finances of it were so obvious. The moral of it was so obvious. And he wrote me this little thing, and I normally don't actually respond to every random email that comes my way, but I did. I looked at, partly because of who referred him to me, and I looked at it, and I wrote him a note back, and I said, I don't know you, Russ, but this doesn't make any sense. I mean, it actually did make sense, but I said, you have no credibility, 0 credibility in any hospital in the Boston area. They're not going to listen to you. You could write anything. Cure poverty. You could send out notes, but they're not going to listen to you. But I invited him to come to my office. And he came to my office, and we met. And I asked him, well, tell me your tale. How did you get here? And I listened to his description of the same story that you just heard Gitanjali speak about how what I heard in his story was the delays getting care. And I said, delays getting care? And listen to the things that actually Kotelchuck said. She sent her husband out. She didn't want to upset her relatives, so she drove to Newton instead of driving straight to the hospital. She was well prepared. She knew signs, but she was knowledgeable. But even so, she delayed. You could hear all these different delays, and actually, she didn't tell the delays of the first story, which had really more to do with being because it wasn't a prematurity per se, but it still was an earlier delivery and a health related. She was in a supermarket when signs sort of came, and she did what everybody does. She delayed, she went home, she rested, because husbands tell people, rest, don't rush so fast, we'll see how it goes. I was listening to those delays, and I thought, now there's an important topic. I knew ACT, the hospitals have been doing work for years, but here was a public health topic. I could relate to public health topics. That's who I am. So that got me excited to sort of start working. Russ and I then started working together, and we decided, well, let's find out if there's is there anything to this topic? I don't really know. It's a great idea. So we did a pilot study, which I'll tell you a little bit about, using his March of Dimes connections, and I got us started. And as you'll hear, people were so enthused that it just added to my enthusement, my interest in this topic. And anyway, Russ and I have been working together on a ton of different activities since then. We eventually, with really Russ's lead, really founded the Day Before Birth, which I would argue is kind of an advocacy group with a kind of consumer perspective on education, practice, policy, and research. And it gave us a reason for talking about trying to expand the way we thought about this topic. Patient-centered care, life course perspectives, CQI beyond hospital efforts, engaging new partners. It was a forum for us. It is only 3 of us, just for the technical record, And, but it pulled off this conference because together we proposed and obtained funding and implemented this conference that everybody's at today. And I agree with Scott. Russ, you should feel really good about this. And this was also a chance for me to say nice things about Scott, about Russ, who has been a fabulous partner in all of this work. And that's actually my conclusion. A consumer-professional partnership broadens and improves our understanding of what it's going to take to implement a national initiative. My other conclusion is don't answer random emails, because you never know what kind of trouble you're going to get yourself into. And here we all are. Okay. So let's talk about cardiac care. Many of you in this room, a few of us have cardiac issues, so we know about cardiac care. And this is weird. We're doing our research, and we one day started reconceptualizing what our research was by looking at analogous fields. So we don't have to start everything anew. Other fields have struggled with some of the same thing. So efforts to improve cardiac care, especially emergency care, can provide important lessons for us in obstetric emergency, prematurity, if you will, care. Improvements in clinical cardiac care, secondary prevention and treatment depend on a person arriving at a capable hospital in time for treatments to be effective. Oh, this starts sounding, I think most of you probably know. You get a stroke. I watched a stroke message on TV today. You have a stroke. These are the symptoms. Call 911. But as you'll hear, they had a few extra messages in there that we miss, and they have. In cardiac emergency care, a lot of effort's gone into programs and practices to get patients to the hospital more quickly so that hospital-based treatments work. If you get there, you live. Oversimplifying, if you don't, you don't. And there's a very high mortality of people who don't make it to the hospitals. So obstetric emergencies can be seen somewhat as analogous to cardiac emergencies. Getting women in premature labor to hospital in sufficient time before delivery for treatment to be effective is critical. It's a really interesting way of framing our topic. And I'm going to read you, this is a paper probably nobody in this room has read, but it's the sort of major paper from the American Hospital Association called Reducing Delay in Seeking Treatment by Patients with Acute Coronary Syndrome and Stroke, a scientific statement of the American Hospital Association National Center by Deborah Moser and 15 other people. And this is the first line of it. Despite major advances in identifying effective treatment for heart attack and stroke, there are difficulties in applying these treatments to care. The weak link in the chain of events leading to prompt and effective treatment is patient delay in seeking care. This has some interesting ideas in it. They did work, and this whole paper is really about this topic, getting people to care on time, an area that we have not really spent enough time thinking about. We've spent our time in the hospitals making sure they deliver a service as well, and God knows there's plenty of room to improve, but getting there early has not been a central focus, not a patient-centered focus of us. They work, so and we can learn from them. They develop patient delay, 3 patient delay phases: symptom onset to decision to seek medical attention, decision to seek medical attention to first medical contact, and first medical contact to hospital arrival. All 3 of those things, if you actually listen to Gantangeli, she had all 3 of those. There were elements in each one of those steps along the way. It's not just getting them earlier. You have to think about what are the decision points people are really thinking about in doing this. And then I just added, just remember, we also still have some hospital delays in getting ACT implemented once you arrive at hospitals. Those are sort of our delay things. But actually, in their own research in the cardiac world, they found the 4th one, the delays at hospital, relatively minor compared to the first set of 3 issues. I'm not sure whether that's true for us, but nonetheless, it was interesting. They identified 4 groups of patient delay characteristics that they reported in what had been studied. Socio-demographic factors, which you all know, basically race, ethnicity, transportation issues. And they commented throughout their paper that this was the traditional initial research theme about patient characteristics. And it is a critical theme because it makes a difference in insurance, in programs for transportation, but that actually was a fairly limited theme. It wasn't as rich a theme as some of the other areas. Clinical characteristics, I'll go through another slide that'll make this clear. This deals with issues about did people have a previous, was this the first time or second time you had help? But they started saying we need to focus more on social factors, isolation, consultation experiences, and cognitive emotional factors. What were people's response to the symptoms? And these latter 2 topics are relatively understudied in their area, but they thought were the most important. And this is I just stole some of the lines from their slide. These are just the factors that they reported, again, much in the cardiology world as in our own world. You know, socio-demographic characteristics. If you're poor or low income, you have a harder time getting to hospitals. Gee, that's not exactly a surprise for our field either. That clinical characteristics, I left some of these on just to show you that if you had a previous heart issue or you had a previous obstetric problem, that didn't actually get you in quicker. You might think that it would. It might make you more sensitive, but it actually didn't necessarily improve things. And that's a problem for us in our health education campaigns because we need to work more on this group that's a very high-risk population. And I also left up diabetes and hypertension as a way of thinking about clinical care, chronic conditions. Women with chronic conditions had a harder time getting into care. Well, women with chronic conditions in obstetrics has been our main focus area for a long time. These are really high-risk people, and they were having a harder time getting in earlier. And smoking, I don't know why smokers take a longer time. Maybe they're self-medicating to slow down things. But actually, it's the same finding that we see. The few studies that have good ACT data for delays, smokers do tend to come in later, so I left it in. But let's look at these are actually the topics that are more interesting to just think about. If you live alone or being alone at symptom onset, it increased your delay. So we do a lot of dealing with women who are not married. That doesn't mean they're isolated, but there are women who are isolated. It slows them down. They don't have anybody else to consult with. Consultation with a physician, this was a really sad one in the cardiac literature. It slows things down. They want you to get to the emergency room immediately. They don't want you to call up. I'm not sure that would be true in our world, but it takes time to reach your provider. And if your provider takes time to reach you back and the provider says, well, let's just wait, this is an issue. I'm going to come back to this in a moment because it's a critical issue for us to think through. Consultation with the family members. Fathers turn out to be they're very cautioning. They tell you, slow down, don't rush it. Relatives, everybody says, just wait and see. It's a pregnancy. Things could go. Consulting with a non-relative, however, got people in earlier. Because non-relatives say, you got troubles here. Get yourself to the hospital. And they're directive. And, and I'm watching several of you nodding your head as I'm talking. These are actually really relevant to our things. We just haven't been thinking about it. Cognitive and emotional factors. In knowledge of symptoms and risk factors didn't make a difference. It wasn't helpful nor harmful knowing the thing. Appraisal of them is non-serious, so people made self-judgments. Oh, just early labor, nothing special. Decreased delays. Waiting for symptoms to go away increased delays. concern about troubling others. I still always think it's the most interesting in your story that you didn't want to bother your backup people who lived, who could have just as easily driven into Boston to pick up your kid, then you drove all the way to Newton, way around the city from where you live, to drop off your kid because you didn't want to bother them. The social context of people's decision. Clinicians think that everybody does everything from their health care, but in fact, we all live in social worlds. That's what this article points out. And our social world is very important in how we actually make decisions. Fearing consequences of seeking help, telling people you're in labor, people are afraid, being embarrassed about seeking help. There's a lot of fears that people have. Correctly attributing the symptom origin was the one thing. So if people actually understood what was going on, that actually made a difference. And self-treatment, which is to say you took aspirin or something to slow down the pain, didn't help either. So I just thought this was an interesting list. I really liked it because it made me think about what's really going on in the lives of women as they're making decisions. There has been a series of campaigns. Most interventions involve community and professional education campaigns, same things that we run. They've yielded disappointing results, and their conclusion was likely because of emphasis on simply providing information without attending to the complex cognitive, emotional, and social context in which treatment-seeking behaviors occur. Okay. They have 4 directions for new research. I won't spend a long time. Obviously, they want to do research on social, cognitive, emotional factors. They want to test new interventions and to kind of move, and this is their critical point. You can't just say, if you have this sign, call your doctor. You have to add a line in there that says, if you have this symptom, there are things that we can do that are beneficial. Finally, the ACT world, they stopped saying, you have the symptom, call. They said, you have this symptom, there are things that make it better now, quickly, and they added that to some of their stuff. They also focus heavily on trying to reach high-risk populations instead of broad universal campaigns, which are good, but there are lots of high-risk populations that we can target more who have these extra social issues. That's what the third one was, and they, again, as in our own field, have underserved populations. Okay, so we need to reconceptualize ACT as analogous to cardiac emergency care. We need to address these same kind of patient social, cognitive, emotional barriers. Plus, we haven't yet done enough research on the regular social determinants, so let's do that too. This does not and did not in cardiac care diminish the need for primary prevention or enhanced hospital-based services. Patient-centered initiatives, as in cardiac care, is just a necessary component of a larger campaign. So that I thought we learned a lot from that. It was very insightful to me. Allowed me to express what we're doing to all kinds of people who didn't initially understand. I want to quickly cover a little bit of research that Russ and I did a while back. There is no literature on patient-centered factors, as far as I can tell. I hope someone in this room will tell me I'm wrong. But that means interviewing people, talking to people. Why were you late? Not looking at the records, which is good, but not sufficient. So Russ and I decided to do this because we got involved in it. So we did a study. I like to call it our initial March of Dimes pilot study on patient-centered factors. This is kind of a proof of concept study, an early exploration of the topic. I wish I had final results of next studies and others to tell you, but this is what we learned in this first study. We took advantage of Russ's work with the mission families in the March of Dimes, and we used the mission families in Massachusetts and in Ohio as our study. We aimed to establish a timeline of activities from symptom onset to hospitalization, to examine a range of family-centered barriers to timely arrival at hospital, and compare early and late arrivals at the hospital to see what we could learn. The methods, the March of Dimes informed people of their study, so if you were interested, you indicated that to the March of Dimes, and then we contacted them. We focused on people in March of Dimes who had births between 24 and 34 weeks, who could then opt in or not opt in. We utilized a mail survey. We had no access to people's medical records, and this was all IRB approved. We got 88 responses from 110 111 people who were positive responders. I will tell you, I can't believe I'm actually presenting this as a study. It's biased, it's a limited sample, but were they enthusiastic? I have to just say, the comments on the side of the page was like no one had ever asked them these things. And one thing I will tell you is, and I know this from other research, all women know the details of every birth and every slight that happened to them that day, whether the nurse was nice, they can tell you everything. And they remember all the events. These are the birth stories that people tell. So this was we didn't restrict it. We did it, I think, for 10 years before. I mean, we could think how to make it methodologically better, but I didn't know what we were going to find. And what I mostly found was the enthusiasm, and this was a great topic and one that we should be studying more. This is a distribution of how many hours before delivery did the mom, how many hours before delivery did the mom arrive at the hospital? Since we didn't have the actual medical record, we chose the time period from arrival at hospital to delivery, which is actually a pretty good measure of thinking about whether there was sufficient time. That's all we were looking at. Was there sufficient, if you had gotten antenatal corticosteroids, was there sufficient time to actually get in and have it, have the treatment to have it be effective? And here's what we found. We found, as I think many other people who might look at this, is there were sort of two groups. There's a kind of group who get there really quickly before delivery and a group that got there in plenty of time. So 40% of our sample got there in we're less than actually 24 hours before delivery. These were the kind of delays people reported. If we just asked them, do you have more than 30 minutes delay, traveling to hospital, reaching a provider, obtaining assistance from spouse or caregiver, attending to personal responsibilities, waiting for emergency medical services, arranging care. It just showed there were a lot of different kinds of barriers. We listed a lot. There were a lot. This was the distribution about how much time it really took to reach the hospital. Most people got there within an hour and a half. But, it was a pretty widespread distribution. There wasn't, interestingly enough, a lot of significant difference between those who got there early and late in terms of before delivery. In fact, the ones who got there the earliest, as you would expect, were the people who were kind of already under active obstetric management. So if they were on bed rest, they were delivered at tertiary hospitals, they had antenatal hospitalizations, they tended to get there earlier. But I have to just say it was appalling to see what a large percentage of people under active obstetric care didn't get ACT treatment early. So there was plenty of room for improvements. The study led to two things: a fuller list of a timeline similar to what you saw from the cardiac. I won't waste our time with this. It's in your slides if you want it. And the development of a new study, which is really trying to deal with this a little bit more, and including a greater focus on racial and ethnic disparities, a wider range of domains to look at, including clinical presentations, and using a non-premature controls, but I don't have any data to report. So I do want to say one more thing about research, a couple more things on this topic. First, the two other studies I could find in the literature were the study by Howell and the study by Lee that examined patient barriers. You know, they looked at samples of who got in and who didn't get in care in time for ACT treatment. And these are really the kind of early research that the cardiac people talked about, sort of looking at what we could see from our medical records. And but they didn't collect data from the patients themselves. They weren't trying, so not to be critical. But I would also say patient-centered research, until maybe this conference, has been a really tough topic to get funded. It doesn't actually fit in anybody's bailiwick. It doesn't, you know, it's not actually obstetric care. It's not perceived as obstetric care. And it's like, where do you go? I hope, ARC, if you're in the back and you're listening, fund us in the future. This is good, you know. And we obviously need much more research in these kinds of areas. But I wanted to speak on one other research topic that I thought was particularly relevant to those of you who are actually in clinical settings, besides doing the first research. The interface between patient care factors and behaviors and the healthcare system practices around initial prematurity assessment and care is potentially a key research area. That interface, when people call and say, I'm in early labor, what should I do, is actually an important area for research and a tremendously important area for CQI activities. But I feel we have to address head-on the real issues that take place during that period. Because if you listen to what I'm talking about, it sounds like I'm going to make every person call every obstetrician every moment. The first pain they feel, they're going to call you. And, you know, the OBs and the maternal fetal medicine people are going to be completely overwhelmed. But it is actually in that key moment, which is one that many of you in this room could study, that is actually really important for research. I just wanted to put this out there. We do need to look at accurate assessment of real versus kind of transient patient worry concerns. That's what you are trying to decide, what the triage nurses are listening for. And they're generally pretty good, but we don't actually know how good they are. We actually never look at whether they've increased delays or not increased delays, misjudged, didn't misjudge. We need to make this an important area. I think it's a really good CQI topic. And I just as an aside, I also want to know, for those who worry about health policy more generally, it's fine, we're all in fancy tertiary hospitals in big cities, this all works one way. But if you live in rural areas or in states where you don't have 7 tertiary hospitals in Boston or whatever, 3 actually, we have 4, the fact that if a clinician is not available at night, their office just says, go to the emergency room. I did a study in North Carolina when I was there in the late 90s, and the major reason for going to the emergency room was sort of well-child prenatal care visits. That they didn't know any other code. They coded them as prenatal care visits, reassurance, other things. It was incredibly costly. The Medicaid folks were blown away at how much money they were spending because the clinician wasn't available, period, or their office doesn't. So it's an interesting area for work. Okay, enough of that. MCH Life Course, just watching time, I just want to say a couple things about the MCH Life Course, sort of the fourth area that kind of got us into patient-centered. And it's a different perspective, and I hope I won't bore you on this particular point, but antenatal corticosteroids is a quintessential life course event or intervention that addresses prematurity, and that prematurity itself is a critical life course experience for too many kids. So kids who are being born prematurely, you make a difference right then and there in their entire lives by what happens or doesn't happen. It's a really important event. Life course theory provides a new framework for thinking about patient-centered initiatives. This is some work that I've been particularly doing. It does encourage us to think about approaches that go beyond just straight clinical care. It highlights the importance of early life experiences and longitudinal integration, longitudinal and intergenerational impacts. And as always in Life Course, our goals are to optimize health and reduce disparities. I'm not going to go through this long slide, but many of you have heard me talk with Amy Fine and others about sort of how to think about Life Course, but I just want to point out that ACT has short and long-term Life Course impacts via secondary prevention. ACT impacts at a critical gestational age, and that access to ACT is significantly affected by social factors, and that ACT itself may be a further source of disparities, amplifying the already unequal impact of prematurity in our society. 2 new ideas are developing in the MCH Life Course world. This may not be the world many of you think about, but it is an important intellectual activity that's happening. And the ones I want to emphasize for this are intergenerational continuity, getting us to think about ACT as a multi-generational issue, and the triangulation of MCH Life Course services, which is kind of a new conception about how reproductive health services are delivered, and it draws us back to the topic of patient-centered in particular. And these were all developed in a chapter that Wanda Barfield and I wrote on preconception and perinatal health and the MCH Life Course, the state of science and proposed research agendas. It got us trying to think, what could Life Course tell us to do beyond what we normally do. Just want to take one slide on intergenerational continuity. It is an intergenerational continuity theme. It reflects the direct impact of the mother's health and the mother's environment on her infant's health. It's definitely a intergenerational continuity. The seeds of the next generation's health and reproductive future are planted in the early experiences of the newborn. And as an aside, we do need more research on what the impact of early experiences over the life course, not just in the next 28 days. The mother and father's health and well-being are also impacted by the health of their infant. Be the infant healthier or not, being more or less healthy makes a tremendous difference in the way the parents' lives are going to be most of you in this room probably are parents, and you know that your health and the well-being of your kid profoundly affects you. So ACT is about the impact on the child, but it's also about the impact on us. And you actually just listen to two people talking, which, you could see what a tremendous difference ACT made in people's lives. So I think we should broaden who the patient is for the impact of ACT. I think it may gain us some political allies and help us think more about it. The triangulation of MCH Life Course service, I need some better jargon than this. It's a terrible term, but it's a new conception about the kind of interventions that we need to do in MCH. And I would argue, and I'll just show you a whole bunch of quick pictures, that all interventions that we have in Life Course and more generally in reproductive health fall into one of three categories: clinical, social determinant, and maternal agency. I'll show you some pictures so it'll make it clearer. That all three categories of intervention are needed to address complex, multi-sectoral health issues involving optimal newborn health. And this includes us having to work in all three sectors to optimize ACT implementation to improve health of kids. So I graph it this way. It's actually a three-dimensional, you could do X, Y, and Z coordinates. It's probably a better way to think of it, but I like to graph it that basically when we try to improve reproductive health, we go and we mostly work in one of these sectors. We often argue for different sectors, but our work tends to focus on one of these sectors. And in fact, after a while, you realize these are the only three sectors that we have. So maternal agency are things like mothers taking on issues around prevention, because it's an internal thing of the mother. What does she bring to this event? The social, emotional, cognitive factors, they're also in this agency. Our health education focuses on this thing. Social determinants, obviously, are social determinants, our insurance, our SES, other kinds of activities, and clinical systems, which is what most of us think we're doing here. And I like to point, you can have progress in each of these sectors. So ACT is usually thought of as a clinical care problem. Most of us here, I suspect that's really where we come from. We're focusing on this as a clinical issue. A failure of clinical compliance, on the part of hospitals or clinicians, a hospital-based quality improvement issue. But ACT is, in part, a clinical problem, but it is more than that. We need to think about multi-sectoral programs that address all three sectors. I'll talk about that in a quick second. Single sector programs, single sector approaches as a campaign particularly are limited. And we need interventions. Each intervention that we do in one sector needs to be thought about how it plays out in these other sectors. It's an approach to thinking about stepping back about what are our interventions. This is a graphic, you're supposed to do both. So in my opinion, one of the historical roots of the failure to achieve better implementation of antenatal corticosteroids has been the exclusive focus on the quality of clinical care. This isn't to say it's wrong, but we have failed to sufficiently address and engage patients or sufficiently taken up the larger social determinants of who has access to ACT. So trying to say a little bit more about this. Patient-centered initiative involved women and families in ACT initiatives as participants and as advocates. It encourages a new envisioning of what patients bring to assuring access and effectiveness of ACT implementation. It recognizes the social, cognitive, emotional barriers we talked about to timely arrival at hospital for effectiveness are actually maternal agency issues. They are in the person. They're patient-centered, person-centered, agency-centered. These can be thought of as, at a simplistic level, they really expand on our already existing prematurity awareness education campaigns. They're kind of linked to now what's happening nationally with PCORI and a focus on patient-centered approaches. And, we need to have in a national campaign a strong focus on patient-centered activities. And then just the fifth topic, because we have a whole session on it, women's and patient-centered initiatives, also focuses on patient-centered activities at this point in time. And women in direct involvement needs to be a critical part of our initiatives. Our two panels down the road are going to talk about this. So what are some interventions that we could do, and what are our recommendations? And I'll stop. Okay. We could educate women we should, as part of patient-centered interventions, not research,
Educate women to know the warning signs and symptoms of preterm labor, but move beyond it to move beyond simply providing passive information to address real decision-making, what really their decision-making issues and barriers to action. We need to educate women to know that ACT is beneficial and that time is of essence in some situations, and to educate women to ask for ACT. Prenatal care in this country came about not because all the physicians told everybody you should get it, it's because people started demanding it. We need to create a kind of demand. Okay. We would be good to have patient prematurity education completed as early as possible so people learned of its benefits early and knew this was a possibility. This may be optimistic. We want to enhance women's ability to self-identify prematurity warning signs and early signs of labor, daily self-assessments, kick counts. There's a lot of activities out there on this. Encourage making prematurity planning a contingency part of a woman's labor and delivery plans. We have a lot of women write delivery plans. You know, they hand them to the hospital. They tell the clinician, this is what I want to see happen. But there's no part of it that deals with what would happen if you went into labor early. You could think about it. It's not actually a bad thing to add this to it. And we could engage and educate fathers around prematurity and ACT, you know, so they won't be useless in crisis and emergencies. That's my wife says, you're useless. We're not useless. Fathers are really an important part of a family, and we could do a lot more with involving them in this. We could also plan and support emergency trips when directed by a provider to an appropriate hospital level, and in particular, I like this one, support policies that reduce the cost and the logistic burdens of emergency trips to hospitals. Maybe we should charge less money for emergency visits to hospitals for pregnant women. I don't know. I'm not sure that'll make it better or worse, but at least let's think about, out of the box, what are things that are barriers that are slowing us down? Support policies that enable women to leave work, pregnant women to leave work for pregnancy care at a moment's notice. That's very difficult for many places to do. Increase a focus on prematurity and ACT education and planning in all MCH programs in the country, especially those serving higher risk populations. And increase prematurity information on social media and strengthen the clarity of our messages and the breadth of our messages on websites that provide early labor information. We have actually some good websites out there, but that isn't actually where people go. We could study where people actually go when they're in labor to get advice, which I think we should do. And so my final slide really is to our recommendations, and I hope this stimulates a conversation, not a one-way long talk. Increase focus on reducing delays in arrival time at delivery hospital for women in premature labor to enhance both initial access and full effectiveness of ACT. That's a really important thing. More research on patient-centered barriers to ACT utilization, and also more research on early patient-clinician interface around prematurity assessment. We just don't study that, but we need to because that's the secret issue. We want to expand CQI activities beyond and, in a sense, before hospital arrival. Hospitals need to just think that they have this longer period that they're responsible for, not when women just walk in the door. Increased knowledge and demand for ACT, for antenatal corticoid therapy. Increase awareness about ACT and premature in all MCH and public health programs, and engage women in efforts to increase ACT utilization. So in sum, we need more increase in knowledge base, more increases in our social strategy, and more engagement of women for political will. So with that, I thank you.
Actually, we're going to start the panel discussion now. Okay. We're going to focus, I think, on this panel on the patient-centered initiatives. Right. But towards the end, if there are also general questions about the introductory material, we'll do that as well. So first of all, I think we should all thank Milt again for answering. Thank him for answering random emails, because one should know that it could be one of you up here if he hadn't answered those emails.
He's persistent. He would have written every one of you in the room, and if so, don't. Yes.
Yeah. So I want us to have sort of an exchange here, but I guess make a couple of quick points. The first is that Milt has provided, and I asked him and we discussed it, a very broad picture here. A lot of things that either are going to require research or is going to take time to figure out. But there are also some things in there that are, let's say, more within reach, right? We arguably have the systems today to measure for each woman the time between the time of arrival at the hospital and the time that steroids are actually administered. If we can do those sort of things, we'll talk about it later in the national data collection. That's certainly within our technological capabilities, but that's the start. That's how we can start addressing the problem. The other thing is, coming from a different background, as many of you know, I'm not an MD. I didn't study perinatal care. The way the apparent approach to the quality system is very strange. Strange because in most quality sessions, the first thing they tell you to do is define the system. And it seemed to me very early in my discussions with Milt that the system was designed as the hospital, okay? So we arrive at the hospital, we give the steroids, and we're done. Thank you. And most of the literature, unfortunately, reflects that, and it doesn't look at the lead up to what happens to everyone before they arrive at the hospital. Are the things that we can do. Another thing I wanted to emphasize is obviously one of the reasons why we focused on steroids is because of its effectiveness, and also because we all know that it's not like streptokinase in the cardiac care or the stroke scenario. It doesn't take 90 minutes, but it's still time sensitive. And it's still something that takes, optimally, we want to have it on board for 48 hours, maybe 24 hours. And I think there's not a great appreciation of the fact that even those number of hours do, on occasion, get squandered. That we saw in our pilot study, again, which is not great data, we saw people, in some cases, losing 3 hours. In other cases, losing more, and this is not even in well documented. I remember, again, a case study of one, but many of you may know this from your own professional experience. One particular survey, woman came in, she arrived on a Saturday evening, the obstetrician wasn't available. He asked her to stay overnight, but she wasn't really evaluated. Came in the morning, realized immediately that there were labor complications, transferred the woman to a tertiary care center. Of course, according to the woman, however, steroids were not administered until she reached the tertiary care center. So a good 24 hours in that particular case went by before steroids were administered. Again, an N of 1. We're here early in the field, but I think we have to recognize, or at least study, these people and determine whether this stuff is real. So now I'm going to sit. Milton and I are going to comment back and forth.
Okay. So any comments from anybody want to give a comment?
More on a personal level, I do think that the focus.
So talking, we can ask. To me, this room is small enough, but nonetheless, we're going to ask people to talk at mics.
Carolina Reyes, Virginia Hospital Center. I really appreciate your focus on the consumer education or patient education, because I do think that we do take for granted that there are a lot of different forms of, there's a lot of information out there, and sometimes overwhelming for women who are pregnant and not know where to go. But I do think that this effort on bringing attention to the symptoms is critical. I think oftentimes, not just the individual patients as moms, or even in our professional world, underestimate the symptoms. Always sort of think, these are women of reproductive age, very healthy, of course I'm not sick, is the kind of thing. And so I do think that this focus is really critical. And certainly there's a paucity of efforts in that. So thanks.
Then Jeff. I'll call on you, Jeff, next.
Good morning, Ann Santadonata from A1. I wanted to thank you for the comments that you made this morning. I think very comprehensive. And one of the points, among many, that I really hang my hat on as a nurse and as a representative of A1 is that there is value in really well-constructed qualitative and descriptive research, especially in an area like this where we're trying to determine what those factors are that influence a woman or family's decision to seek care. So I thank you and applaud you for emphasizing that point among all the other very, very important points. Thank you.
And Deborah Moser is a nurse, and this came heavily from the nursing community. It was the broader Heart Association, but the nursing community was really important in thinking about this. And I agree that having, now that I've looked at this, I do think it was a pilot study. I recognize that, but our N of 88 turns out to not be so small compared to the other studies, because it is hard to actually engage people in this kind of work, and it is qualitative work. And I'm a numbers guy, as most of the people in this room know, but it was really important. Jeff? There's 2 mics, actually, for the future. So.
Hi, Jeff Gould, Stanford. This is a really amazing talk for me. I think that your emphasis on thinking of quality improvement is not just centered of when you give it in the hospital, but really looking at the root cause and saying, if you're going to do QI, you have to really be responsible. You can't say, well, the patient got there too late and kind of call it quits at that. And I think that because of this, it could be that an action initiative could really be an important model for how to conduct QI in the future. I think one of the things we're facing is that a lot of QI is based on a single hospital, where hospitals work in networks. And unless you really have that network at the table, you're going to have limited impact. And I think the same thing is even more important when we talk about patients. And a lot of the patient QI, again, is kind of focused on what happens in the hospital rather than what happens in the life course. So I think this is a really important way to think about quality improvement.
Then I'll call on you.
Hi, my name is Donald Dudley. I'm from San Antonio, Texas. Being a native Texan, we obviously will obligatorily take the opposite stance on whatever is proposed. And I would like to, there is a little bit of a danger here we got to be careful about, and that is if we plant an expectation in the patient's mind that they're going to be getting antenatal corticosteroids because they're coming in with some symptoms of prematurity, and she's assessed and decided, she really doesn't have it, because we're so bad at identifying those patients who are actually going to deliver preterm. What was it, Ron? 80% of women who presented in preterm labor or symptoms of preterm labor actually delivered preterm, didn't deliver preterm. So only 20% actually delivered preterm. So, and those women would get steroids anyway, so we're going to be over-treating the population, and that potentially has danger. There is animal data that potentially antenatal steroids could have some detrimental long-term effects by altering some fetal programming that occurs. That Peter Nathaniels at our place has been discovering in the non-human primate. So there is a danger to over-applying a therapy here that we got to be worried about. I think we saw this a little bit in our own experience with the Less Than 39-Week initiative, where women actually had very valid and needed to be delivered before 39 weeks, but they had the whole idea they needed to wait till after 39 weeks and plant it in their brain, and they actually were resistant to that, to potentially their detriment. So we got to be a little careful there. And really, to me, the biggest issue is adequately identifying those women who are actually going to benefit from the steroids, which we are woefully terrible at, I think, as a group, not just we in Texas, but we everywhere. So that's just my comment.
Okay. So I want to comment you raised 3 or 4 different really important points. And the most important one I just want to say is, this is meant to be a conference where we're talking to each other. So, and we want disagreement. We want us to balance these things. So I just want to applaud that, and I want everybody to feel free. That's for the spirit of this meeting. This is actually not, despite my talking too long, meant to be long lectures on topics. It's meant to be more interactive. Secondly, the danger of over applying it. That's why I wanted to focus on this sort of that 20-80% mix that I was saying. That interface of decision, we have to study it. We have to look at it. That's a critical issue for us, because it's an unstated reason for being kind of cautious.
And I think there's good reason to be cautious in a way, but there's good reason not to be cautious, and I'm not sure where that balance is, and we have sessions later that are really trying to talk about our ability to enhance our preterm labor assessment. So, these are all interrelated parts of this. And then you had one little interesting comment about life course long-term impact. This is a life course. These are life course events, whether needed or unneeded, the treatment. They are life course events, and I do think we need to study and look at them more. I applaud. So I didn't take, you may be from Texas, but we won't hold that against you. Yeah.
Hi, Jennifer Baylor from Metropolitan Medical Center. I'm intrigued a little bit about the quality and being so focused on the hospitals. I agree with you completely, but that's because we're looking into the streetlight. That's where our incentives are. If we're really going to start talking about getting women in earlier, that ceases to become a hospital problem and becomes a public health problem, in which case we need to be looking at other sources of funding and other sources of influence on this. Does the business community have a vested interest in keeping their healthcare costs down, keeping prematurity down by getting their women in early? So what are the other community resources we can leverage to work on this with us and to fund this? Because the hospitals don't necessarily have a great incentive to take this work on by themselves.
So I don't want to be dialoguing, so we'll let others talk, but just to say, that's why political will is in those slides. That is a political will question. Where do we get the resources? Who do we involve? Who are our partners in this? I think those are really important issues. But I don't want to leave the hospitals off the hook completely. They are actually providing the care. Very few of the women are coming in who they've never seen before. They are providing the care. So it is in their network, and it is much broader than that, and I agree with you.
Sorry, and just we have some material on that particular question that we held to the end of the conference towards the concluding statement. So we'll hold that question for then.
Some finances, good point.
You can raise it again.
Milton, just a fabulous start for the meeting and really talks about why we're here, and thank you for doing that. I'm very glad you brought up the patient pieces, because I think that's probably in some ways the most complex and may actually be the hardest of the equations to try and address. From a public health perspective, I think about women needing to get flu vaccine, and that's pretty ubiquitous, and we put it pretty out there, and the risks are really, really low, and we do still really, really lousy at doing it. So the patient side is going to be hard. I will say I think there's a patient side, there's the provider side, and there's the hospital side, because most women don't necessarily go straight to the hospital without trying to interface with that provider, and I think that's going to add to the complexity. I don't know if we really want to tell women, though, that they would need to get antenatal steroids, because do we tell them they need to get antenatal steroids? Do we tell them they need to get dextromethasone? Do we tell them they need to get betamethasone? Or do we just really need to tell women that they need to get into the health care for early preterm for a series of things that may need to be going on, of which antenatal steroids is one? Because I just think from a behavioral perspective, it might be very hard to specifically target one drug.
Right. Well, I don't disagree with you. I think that's our challenge, to figure out what's our message. We just haven't attacked this issue. Is it better to do one thing, to do a host of things? It's a conference on antenatal corticosteroids, so I'm going to advocate for talking about that. But I do think creating an awareness of benefits, that there are treatment benefits to coming in early. People think of it, this is now anecdotal. People think they go in premature labor, they're thinking labor, it's like they're not expecting this. They're not thinking that there's that's like a kind of a weird world. I fully understand that, but I do know that in our other public health worlds, creating demand, creating awareness, and creating awareness of benefit, that there are beneficial things. Clearly, that's what the cardiac literature found that it was much more effective once they stopped just say get in early, but said there are really things you can do. And whether it's a package, I don't think antenatal corticosteroids is the only thing that we have. I hope we'll have a whole armature of things. But this is a really powerful one, and we're not doing it well. So I don't know.
To which I just quickly add, I think we should also continue to remember that if we empower women, and they know perhaps that symptoms at 24 to 34 weeks might be a little bit different than symptoms later. I think most professionals would like to have more time to make and apply what technologies there are, both the preterm labor assessment that are available, but to have women and families, for that matter, be a partner in the system, I think that's a better angle.
Well, using that, I'm watching time, so we should start. Oh, you have one last question. Is it a quick one, or?
I'll make it really quick.
Okay.
So I'm Jackie. I work for Hologic, but wanted to answer more from a different perspective. I actually gave birth to my son a few months ago at 27 weeks. So this is all an interesting talk, and so I thought I'd offer, a little embarrassing for me to admit it, but on the way to the hospital, I stopped and did a lot of errands on my way because I didn't think it was that big of a deal. I sat in the bottom of the hospital filling out paperwork because I was so early and I wasn't in the system yet. Talked to my husband on the phone on the way up because I was like, oh, it's okay. I'll just maybe get a negative FFN and go home and we can have dinner later. And really kind of delayed getting myself there. Didn't know where the hospital was because my doctor was down the street, so I wasn't sure what entrance to go into, didn't know where to park my car, didn't know where triage was in the hospital. So all these things, as I'm kind of sitting here listening to you guys talk about it, there are little things that could make a difference that might not take a lot of money or a lot of education, just to really help women understand how to navigate through the system and get the care that they need to. So it's just my thought.
That's a really nice thought and thing. I hope everything's well with your child. And just to say, the point of this is patient-centered activities are one of a whole host of activities that we need to do. It's not, we just happen to start on this one. We'll have plenty of chance to continue many of these conversations as we move on to the next session. Thank you.